give the kind of care that over the years we have learnt is really good dementia care. And so 2020 brought in a period which for all of us was entirely abnormal. I call it the new abnormal because I cannot imagine that we could consider the sorts of things that happened during those 2 years to be normal to humanity. But it was a time of panic. And so I want to preface what might come across in some situations or some cases as sounding quite critical with the deep understanding of where we were at that time. We did not know what was going on. We were fearing, deeply afraid because of the possibility that millions of people around the world would die. And therefore we had to trust what we were being told. And certainly from the stories that I was hearing from the care homes, people were doing the very best they could. But because of that incredible, overwhelming pressure to focus on the issue of infection control in this time of unknowing, we forgot so much of what we knew about good dementia care. And in good dementia care, we draw on the lessons of many people who've spent a lot of time looking at how do we make the lives of people living with dementia more meaningful, happier, just more connected. And so one of those people was Tom Kitwood, who put together the notion of person-centered care, the importance of having love at the center of everything, of deeply knowing the individuals that we care for in terms of their identity, in terms of the things that they've done in their lives, in terms of the people that they love and are attached to. And the second, almost like movement, I would say, of people involved in really high quality dementia care, and I'm going to draw on their principles and the domains of well-being during the talk, is the Eden Alternative, who basically register care homes according to their principles. And what I learned was that despite the difficulties that, for example, the care homes were facing in that time, those people recognized, like in this respondent's statement, that surrounding the people with dementia with love and care made the world of difference in a time of great fear and uncertainty. So let's quickly look at what the Eden Alternative calls their domains of well-being. So human well-being relies on many things fitting into place. Being well known, that idea of person-centered care, continuing to grow and develop. This one I find is one that disappeared: autonomy, the sense of having freedom and choice, the freedom of self-determination to decide what you want in your life. When I looked at their description of security, I was fascinated because security seemed to rise to the top of our list of concerns, and it was around safety and infection control. But in fact, the first things that come up on their list of securities are freedom from doubt, anxiety, and fear. And I don't know about you, but I know from my own life that doubt, anxiety, and fear were probably one of the most prevalent feelings that I experienced during that pandemic period. Connectedness is also incredibly important, particularly for people with dementia, because, you know, in Africa, we have a saying that a person is a person by means of other people. Umtu, ngubuntu, ngabantu. And it basically means that we know who we are by virtue of our connection with other people. So I will speak a lot about this one, so let me not waste time on it now. But I also have a deep belief in the value of being connected to nature, and with the stay at home and stay indoors orders that so many of us were constrained by, that also became very difficult. Meaning also became very difficult to express because of isolation. And I have to say that those 2 years of lockdown were for me a time of a lack of joy, because the spontaneity and the delight that comes from engaging with those you love was altogether absent. So Eden also, in addition to its domains of well-being, has a number of principles that it has come up with. And the first one speaks to what one of the respondents in this survey that Stride conducted called the plagues of nursing homes: loneliness, helplessness, and boredom. And Eden says that these three conditions are incredibly painful and destructive to our health and well-being. And while our focus seemed to become laser sharp in terms of health being the absence of this particular disease, it is not just one disease that actually creates our ill health. Ill health is also about the loss of the things that it takes to become and remain human. And in contrast to that first principle, the next three principles I'm going to share are the ones that are the antidotes to those three conditions. And I just found this most beautiful picture, which to me spoke of the first one, the access to companionship that we desire, and that being the antidote to loneliness. So if we are looking for a life of well-being, one of the things is that it's absolutely essential that we have the companionship we desire. One of the problems with dementia is very often people are seen as absolutely unable to do anything, when in fact they still have many capabilities left. And there's this thing that I learned from an occupational therapist, a term called learned helplessness, when we do things for others to the extent that they forget how to do them for themselves. And all of us as human beings love to feel needed, wanted, and to have a purpose, to be able to give our gift. And so if we can continue doing that, we no longer feel helpless. And thirdly, if we have variety and things happening that delight us, we are no longer bored. And so this is one of the pieces that I would so pray that we could remember in the forefront of our practice, if ever faced with this sort of crisis again, that quite honestly, if I was to judge whether this gentleman would have been made ill by those two loving granddaughters, I doubt it. I think the love, the oxytocin, the well-being, the strengthening of his immune system through the fact that he is so adored by his family, frankly, I think that would have kept him safe. But I am just speculating there. So what did we all experience in the global response to COVID? First, we had all these terrifying images of this thing we couldn't see. And every time we listened to the radio, turned on the television, we were given lists of the numbers of people who were positive to this test. And the fear that we lived in was reiterated and re-stimulated every time we read or heard the news. And there were various types of fear that we encountered, one of them obviously being the fear of disease and death, which generated that single-minded focus on infection control. And ironically, that infection control focus also strengthened our fear of that disease because we were constantly reminded of its danger. They say that there are two fundamental fears that humans feel. The one is the fear of death. We've spoken to that. The other is the fear of abandonment, because when we evolved, had we been abandoned by our clan, we would surely have died anyway, because we couldn't have looked after ourselves on the African plain without our clan to support us. And so that deep fear of abandonment was so present, particularly for elders in care homes, when those lockdown orders prevented the visitation of those people. Certainly in the first part, it was very, very strict, became a little more allowing later, but that prevention of access to loved ones really generated a deep fear of being abandoned. Interestingly enough, about 2 months ago, after the lockdown regulations had ended for care homes in South Africa, I was invited back to a care home to give a talk. and was told that there was still, particularly older women, widows, who, despite the relaxation of lockdown protocols, refused to come out of their little units because they had become so scared of going out, because they were convinced they would catch this disease and die. And so a fear of going out and of participating in our communities has stayed with some people for a long time. And then, very sadly, a fear of other humans. I remember standing in a queue at our local shopping center, and somebody with absolute terror in his eyes forced me to step back because I'd encroached too closely upon him. I find that incredibly sad, and it is exacerbated by the PPE, by the costume of COVID. And here I'm speaking specifically to people with dementia who had no clue. They could not make sense of this. And to have people looking like some sort of an alien approaching them without the ability to read their expressions, to read their faces, to read their lips, because many of us become hard of hearing as we age. That all contributed to a deep and lasting fear in the vulnerable. So many of you on the call will be very well aware of what fear does to our brains. And I think a lot about this because I don't only work with the caretakers of people with dementia, but also with generally young people with exam anxiety and things like that. And we know that the brain literally shuts down when we're under a state of fear, because that amygdala, that survival part of our brain, the fight, flight, freeze response, causes us to go into a situation where all that is important is that we should either sort of defend ourselves or run away from what is potentially going to harm us. And in that process called amygdala hijack, the higher order thinking parts of our brain actually do shut down. And we become less likely to make wise decisions or creative decisions, and in fact less compassionate, because right now we're in a state of survival. And in the case of people living with dementia, this is extremely important, and a reason why my little mantra that I always share with people looking after loved ones with dementia is keep them feeling safe, calm, and loved, because that's the opposite of fear. And when people are feeling fearful and they have no longer got that ability to restrain their emotions because of their dementia, they're very likely to react badly. And therefore, that thing we call behavioral and psychological symptoms of dementia comes out when, because of their fear or their anger, they express that rather than feeling that safety that keeps them calm. And this terribly important survival response is only meant for short bursts of fear. We're not meant to live in chronic fear, but we did live in chronic fear for those 2 lives. And another irony that is so obvious if you are interested in holistic health, in mind, body, spirit health, is that when you live in a state of chronic fear, what happens in your body is the stress hormone cortisol becomes heightened. And what that does to the body, ironically, in a time of plague, is it suppresses your immune system. It also causes an increase in inflammation, and we know that so many of our chronic conditions are inflammatory. And then, very significantly, not just for us, I know my own memory declined during COVID because I wasn't in contact with many people. I wasn't having many conversations. My loss of words was shocking to me. When a person's brain is in any case compromised by their dementia, the fact that high cortisol impairs the brain further is really something to be concerned about. So the lockdowns happened in record time. It was immediate, and there were unprecedented changes to the lives of all of us, but to elders in particular. There was the separation from loved ones due to the stay-at-home orders and the lockdowns. There was a reduced access to medical care, to social services, to respite care, which had an impact on carers who were exhausted. medical care is so important in old age because that's when we have so many other things going wrong with us. And it's so difficult, it was so difficult in that time to have those other concerns dealt with. We also found groups and activities cancelled because people weren't allowed to participate. And that has a massive impact on a person's cognitive and social health. Can you imagine the horror and the fear of being quarantined, literally in solitary confinement as a person with dementia? Why am I in my room? Why am I alone? This is something we do to hardened criminals. And yet to the most vulnerable in our community, they were being locked in their rooms, fed on polystyrene trays. I don't know. I cannot comprehend that. The distancing, the masks I've mentioned. And then sadly, and particularly in the UK, very questionable medical interventions were taking place in old age homes at a time when there was no family oversight because family members were not permitted to visit. So once again, the Eden Project reminds us that we are not just physical bodies needing fixing. We are whole human beings, and all aspects of our well-being, psychological, social, physical, and ecological, in fact, also need to be borne in mind. In summarizing the responses to the STRIDE research that I was involved in, I'd just like to read this because it's a very, very good summary of what so many of our care homes were reporting in South Africa. The loss of physical contact with loved ones has been the most distressing factor. Isolation, confinement, lack of stimulation, distancing, mask wearing, and hygiene protocols were all mentioned as problems. These changes resulted in feelings of anxiety, confusion, loneliness, depression, and irritability, and sometimes in aggressive behavior, which I've explained. There were also reports of accelerated cognitive decline and loss of sensory acuity and communication skills. And during the period of, could you mute, please? During the period of lockdown, there's been a lot of research that's gone on around the impacts of lockdown on the elderly. And so here are some of the statistics that have been reported in these studies that I quote below. So obviously, we couldn't do what we usually do because we weren't allowed to be in contact. So 70%, and a lot of this is actually people living at home. 70% of those people in that study abandoned their previous daily activities. Very little stimulation going on. As a result, many declined cognitively. Many of them had worsened mood and behaviors. And then you can see that the emotional aspects were really significant: depression, apathy, anxiety, agitation. But also, because this particular study also looked at people with dementia with Lewy bodies, where delusions and hallucinations are very often a factor, and deliriums also increased. And because people were not as physically active, their mobility suffered. And as a result, there was an increase in falls. And as we all know, falls are devastating in the elderly. This picture, which I saw on the internet about a year ago, was to me one of the most tragic pictures that I saw of what happened to us as loving relations in COVID in care homes, some of them, not all of them. Here is an elderly wife of this gentleman who you can see has pretty much lost his interest in life, kneeling in the cold on a hard concrete path, looking at her dearly beloved through bars, almost as if she were looking at an animal in a zoo. There is a young woman who probably doesn't even know this gentleman because maybe he can't tell her anything about himself anymore. And she is permitted contact with this gentleman, while this woman is pining for him, and his condition is deteriorating markedly, no doubt, because of the lack of her company. And so The lockdown environment was definitely new and definitely hostile. People's routines were disrupted, and we know in dementia care that routine is really an important means of keeping people feeling connected to their world. People lost enormous amounts of confidence. I did, and I don't even have dementia, regarding not going out. People had many functional declines. Not being able to practice doing what they always did led to forgetting those things. Loss of quality of life is so obvious. And although telemedicine had an enormous impact, a very positive impact, during a time when people could not access their GPs, particularly for a person with dementia, it is no substitute. A person with dementia cannot understand being spoken to on a phone by someone they've never met to try to explain what's going on when all of those capabilities have gone. So we really have to have compassion and bend the rules that seem to make sense, but which make a person's life fairly intolerable, because we cannot provide that loving human contact and support that they desperately need at a time of so much forgetting and so much decline. Perhaps the biggest thing that has jumped out at me in doing the research for this talk is the issue of social isolation and how it leads to loneliness, a feeling of neglect and exclusion. And fascinating, because this particular research had gone on for, I think it's an 11-year longitudinal study, how it leads to shrinkage of the brain. And this is actually not even including the loneliness factor. This is standalone social isolation. Leads to shrinkage of the brain. And in fact, in that particular study, they saw 26% increased risk of dementia in people who were socially isolated. And again, if you think of our evolution as human beings, we are fundamentally a social species. And so if that is taken away from us, it will have fundamental impacts on our well-being. And they found, as a quote, those who were most socially isolated had lower volumes of grey matter in brain areas responsible for learning and memory. And so Professor Feng from Warwick University pleads, during any future pandemic lockdowns, it is important that individuals, especially older adults, do not experience social isolation. It has had an unprecedented impact, and this other study showed that people who were more anxious and depressed during the COVID period also saw their short-term memory and ability to focus worsen by the equivalent of 5 to 6 years of natural aging. So the deterioration was incredibly and markedly, actually you could measure it. It was measurably faster. And what she presumes is the factors that that cause this unprecedented impact were anxiety, as we've mentioned, the fear factor, and the long periods of lockdown and isolation. So I have to ask myself, was this all a terrible mistake? And another tragic photograph was this elderly lady sitting in her wheelchair with her mask slipping down and asking on her poster, or saying on her poster, I would rather die of COVID than loneliness. And in fact, during the STRIDE research, I came across a story of an elderly woman in Canada who, when she heard that they were going to go into second lockdown, actually requested euthanasia because she could not face going through that isolation again. And Jay Bhattacharya has stated that lockdowns are the single biggest public health mistake in history. And just as an aside, so many of us, myself included, have experienced the economic devastation and, added to the social devastation of the way in which we responded to this unknown. We really need to think twice in future. So I ask, how did we forget not only the principles of good dementia care, but how did we forget the value of our human rights and the rights of elders, All we know about holistic health and health promotion, and all we know about natural immunity and what the immune system needs in order to function optimally. How did we forget what we know about medical ethics, the Hippocratic oath of do no harm, and the need to give informed consent? And how did we forget all we know about high-quality dementia care and being human, the importance to every human being of their extended family, of their community, and the qualities of humanity, not only the love, but also our ability to be courageous and our love of freedom. And so once again, Eden says that we are more than our medical diagnoses, and medical treatment should support and empower us to experience a life worth living. And for me, having inquired into the lives of people who were kept indoors, kept away from families for so long, I do not know that what they experienced was a life worth living. So I wonder, because many times in my life I've made mistakes, and I'm not afraid of making mistakes because I know that often it's the mistakes that have taught me most and most useful stuff about how to go forward. So I'd love to know, are we willing to face what happened squarely and compassionately, and to reflect upon it and to learn from the mistakes? And I'm not saying that this will be easy, because at the same time, there was the overwhelming need to protect people. So that is a given. But there was the other side of it. Are we able to take responsibility for what happened? I think we need to grieve. I think the losses of COVID and COVID lockdowns in particular need to be grieved. I think we need to say we're sorry, and I think we need to forgive. We need to forgive ourselves. We need to forgive one another. We need to forgive those who really believed they were doing the best they could, because that's what we generally do. We do the best we can. So are we willing to do things differently next time? Because there may be a next time. There certainly will be a next time. And what might that look like? How might we do it in a more humane and compassionate way? So I'll finish with, again, the Eden alternative. We need to build a collaborative, that's coming together, resilient culture. And that is a never-ending process. We need to keep learning from our mistakes as well as what we do well. We need to develop and we need to adapt. So we need to be able to do it differently next time. And we desperately need wise leadership. We need courageous leadership. We need people who are willing to stand up and say, I see what we're doing, but it is not helping. It is not leading to meaningful change. And so I leave you with this picture. Life is short, and especially for people at the end of their lives, life is very short. Let's fill it with love. Thank you very much.
Thank you, Dr. Alice. It was absolutely what I call emotionally indulging. I think the figures that you presented, particularly with reference to the fear, I think the fear remains. It has not disappeared. It remains in countries like India, where the number is huge, and where we are talking about the numbers. We are talking about 130 million people over the years 60. And we are all worried about elder abuse. And you have also mentioned very rightly about isolation, and touched upon an important aspect of human rights. Did we forget? If at all we forgot, how? I think there are countries where human rights of elderly may not even be discussed because of the lack of economy and lack of political will. And we are talking about people where we are now talking about care of people in institutions. I think we have seen very sadly what happened in Europe, particularly Europe and Canada, where people were, just dying, absolutely dying, nobody to take care. I think when you asked ending the question with next time will happen, next time will be there, what did we learn? I think wonderful, very nice way to start the program today. And thanks a lot once again. And we will not spare you. We'll always keep inviting you to talk because your data is very interesting. And we would see whether we can bring out a document of all these proceedings of 3 days into a document that can be useful both in India and outside India. Thanks once again very much. Now with
Thank
this,
you
I do not want, thank you so much, Alice, once again, thanks. Now, can I invite Dr. Ravi Samuel now? And Dr. Ravi Samuel, it is, yes, you asked for more time. And I'm very sure there are interested participants are very interested to learn from you. Here is your time to talk. Thank you.
Thank you very much, Dr. Gangadharan. It's wonderful that you keep doing programs to educate, to improve the lives of elders. I wish to focus this presentation for the lay people and also the professionals. For those who are not very familiar with the dementia scenario, I'm also going to cover a few clinical aspects as I talk so that you can catch up with what happens in a real life dementia patient scenario. The caregiving process is a bit complex process where there are different dynamics involved. There is a primary caregiver who is providing the care 24/7. Sometimes they may have to sacrifice the sleep, or sometimes they may have to miss their meal to take care as the dementia progresses. Then at another point, the formal caregivers may get involved and may train them or support in the caregiving process. Then comes the NGO's role, which is very, very important. Educating the family, educating what they should do and what they should not be doing, of course, and the government policies and programs are very, very important. About 20 years ago, none of us knew much about dementia. There were even questions whether dementia exists in the country, but today we know it's a very well established reality that many people are trying to cope with. Always when a major illness is diagnosed, the caregiver first thinks of providing basic care. Once they give the basic care, then they want to give a more specialized care. Otherwise, they feel very guilty. So they go specialist after specialist after specialist, chasing cure. And there will be someone who is not even a medical professional promising them cure, and they will go spend a lot of money and exhaust their finance, leaving very little for the long run. The mortality study shows the patient can survive anywhere between 4 to 12 years. So that's a pretty long time in which there may be many medical challenges and they may need to have finance to fund those emergencies. So very important that we educate the family about the goalposts. If they are chasing behind cure, then they will be very exhausted. They may get very burnt out. If they have very realistic goals, then it is easier for them to regulate the caregiving process, and also for the patient it's easier because whatever happens with the carer reflects on the patient. Then they start expecting to provide extraordinary care for the patient and finding it very difficult to produce that after a point of time. So both the patient and the caregiver require enormous handholding in the whole process of dementia care. Now, there may be, due to the damage in the brain, sexual disinhibition, which can prove to be extremely embarrassing for the family members. So you will be looking at a very dynamic situation where you do not know what is going to come up. So a very proactive services are required. Patient's physical health is affected. Patient can be very restless. They may be not sleeping. There is a case where when we did a X-ray, we found that the person had a fracture. That's why he was not able to sleep. The family could not recognize it at all. It was a shrewd clinician who thought of doing a X-ray to find out whether the bones are intact. Mental health of the patient will be severely compromised. To give you an example, the moment that someone has memory loss, everybody will take it upon themselves to question them, to test their cognition. Can you tell me my name? Which month is this? Which year is this? Tell me, how am I related to you? This will further enhance their cognitive disability. Also make them socially embarrassed, because we find that they are emotionally intact but cognitively declining. So they may go through a lot of sadness that they are not able to make sense. They may be going through a lot of sadness because they are not able to put things together and understand in a proper manner. So they may, a person may look very familiar to, just imagine if I meet Dr. Gangadharan tomorrow and do not know who he is and I do not remember his name. It will be very embarrassing for me because I know him for years, but I'm unable to recollect his name. So a lot of mental health issues forced upon the patient over and above what they might suffer due to progressive brain damage. Every part of the brain carries some function. When that part of the cells are affected, the patient may go through a loss of functions. Similarly, social interactions. I was listening to the questions raised by the audience. How do we prevent dementia? Social interactions are the key to prevent dementia. If you are socially very active, networking, socially interacting with people. Alice was talking about social isolation during the pandemic. Social interactions are a must if you are thinking of preventing dementia. The knowledge and skills of the carer means a lot, and how we enhance the carer's knowledge and skill will depend on what proactive role the NGOs play, because it is the onus is on the NGOs to create that knowledge and skill. We create knowledge, but skill, I do not know. I'm not very sure whether we develop skills in the caregivers. The diagnosis of dementia is a very global one, where the caregiver goes through lots of confusion, from emotional satisfaction of taking care of their elders to a complete exhaustion and inability. So a counseling process is very, very important by a trained social worker or a psychologist who is aware of the entire process of dementia, to enable them to cross over each stage. The problem right now is everybody Googles. If you tell a patient you have this anxiety disorder, or if you tell them you have monosymptomatic hypochondriacal psychosis, immediately they will go and Google it and they will look at the worst case scenario and get all worked up. I'm sure some of you have also done it for your own headaches and your stomach aches. So an overload of information actually causes a lot of strain. So we need to customize to the basic level what is relevant to the patient and what is relevant to the caregiver and what they can comprehend. To give you an example, a patient who had wandering tendency, the caregiver just wrote a small board, wet paint, and put it up on the main door. So the patient used to go up to the door and come back because nobody touches wet paints. So there are very simple solutions to major problems. So we need to look at how we solve problems for the carers and the patient instead of making it more complex aspect. Physical health is very, very important. Regular checkups are mandatory because They may not be able to tell you what is going on. They may suffer from pain. They may have restlessness. They may have sleeplessness. What we see may be different from what they are suffering. So very important that a medical practitioner screens them every quarterly to ascertain their health status. Mental health is very, very important, particularly in the initial stages of the dementia, because that's the time they are aware that they are going through memory loss. They are not able to understand. They are not able to put things together. But as dementia progresses, they may get into psychosis. So a team of professionals are important. The psychiatrist to monitor the medicines, the psychotherapist to do psychosocial education, give supportive therapy for the patient, talk to the family members, resolve conflicts. In the event they are moving the patient to an institutional care, to facilitate house visits, to facilitate family visits to the home where the patient is staying, all those need to be coordinated by the social worker. So it is a teamwork, and it can be very effectively done with very minimal resources. CBT has been very effective in improving the relationship with the carer, because sometimes the carer get overwhelmed. Sometimes the patient goes through depression in the initial stages. So CBT is a very well proven therapy to enhance not only the mood, not only the behavior, but also the overall functioning and the family interactions. Then comes the psychosocial education, what they need to know and how much they should be knowing. Only if a person has got disinhibition, sexual disinhibition, they need to know all about it, and they need to know how to overcome it. Otherwise, they will simply be worrying as to when the patient is going to behave inappropriately. But that will happen only in the frontal lobe dementia. If he has got general Alzheimer's disease, he may never have this kind of specific sexual disorientation and sexual disinhibition. So we need to customize. The skill and mastery of the carers are key role in enhancing patients' well-being. The more knowledgeable a patient's caregiver is, the more skilled they are. That's why we encourage carers to come and share, because when they share, they have a sense of mastery. I solved this problem. There was a man from a village who came and told us his father had wandering tendency. So he removed the gate in the fence and put something which represented the compound wall all through. So when the patient gets out, he will only see the compound fence everywhere, but not the gate. Only the family knew where the gate was. They will silently go out and come when the patient is not seeing. So they solved a major problem of wandering by a very simple technique which did not involve much cost at all. So the skill and mastery that the caregiver develops is very vital for them to happily take care of the patient. Otherwise, we'll be talking in terms of burnout and exhaustion. Sometimes we researchers put words into their mouth by asking, do you feel a sense of burnout? Do you feel burdened by caring? Certainly, some of them, they do not. They are very happy to take care of their father, mother, father-in-law, whatever, mother-in-law, because they have given them something for which they are trying to do something in return. So we need to be very careful as to what we are probing with the carers. Carer counseling is very, very important to help them deal with their emotions. Sometimes they may inadvertently cause the problem. If they are very agitated and if they are giving a quick bath to the patient can get very agitated. And then they may come and report to us that the patient is getting agitated while giving bath, but actually their style of giving bath can trigger. Similarly, the dressing. If someone is used to long trousers, if you put them on shorts, then the patient will obviously get very upset. They may go into a very deep depression because they're not comfortable with what they are wearing. So we need to look at carers' issues without, of course, blaming them. Well, what is the roadmap to dementia care in India or even for outside world? One is information support to the family. Second is home care support. We need to have a home where patients can be admitted and taken care. Also, we need to have large database about dementia care because we need to use artificial intelligence to know the trajectory of different psychosocial and medical factors so that we can predict what will be the care need for the patient and accordingly provide the care instead of leaving it to the carer to decide what kind of care they need. There was another question, how to prevent cognitive decline. Well, you can prevent cognitive decline by very active cognitive lifestyle. If you're socializing, learning new things, participating in as many activities as possible, definitely you will be able to prevent cognitive decline. So to conclude, there is a need for a big data to know the trajectory of care needs, and the future is in the hands of the medical professionals, the psychologists, social workers, and also the IT people. Thank you very much for this opportunity.
Thank you so much, Dr. Ravi Samuel. I wanted to tell you, I did not ring the bell. Somebody else was doing that, one of the participants. My apologies.
It was my phone, sir.
Okay, so you are the culprit yourself.
Exactly by 20 minutes.
Oh, I was wondering, I said, what is this without my talking is doing? Very nice. Now, before I really do that, I think there was a question that's been addressed to me personally by one of those, persons. Let me check where it is. 1 minute. I would like you to answer that. Though it may not be totally, exclusively yours, but still, 1 minute. Priya, do you remember? Can you tell me the Priya? Okay. Priya says she was asking, kindly highlight on the therapeutic approaches in the management of behavioral and psychological symptoms of dementia in the elderly. That's the only question that you are going. I request you to answer, Dr. Ravi.
Right. So the first thing we need to do is psychosocial education. We need to, as I said in multiple times, we need to educate the carers and the patient initially. Then comes the role of CBT, cognitive behavior therapy, within which you might do reminiscence therapy, or you might only focus on enhancing the mood, or you might focus on specific behavioral aspects like enhancing socialization behavior, enhancing appropriate behavior with the family. So CBT is a very comprehensive procedure through which we can focus on multiple components of patient and the carer.
Thank you so much, Dr. Ravi. I think I would stop questions now because we are already 4:29. And so we'll go to the third speaker, Miss Sugavana. I think we would like you to start. Sorry, Sugavana, but let me tell you, the attendance is good. People are interested in learning. And I'm sure, you'll have some, thing to share. Now, I think kindly keep in mind when you're talking, if you're able to touch upon, not necessarily to do that, causes, prevention, prognosis, management, palliative care, awareness creation, drug discovery. Leave the drug discovery, other 6 points in case you're covering that. I think Dr. Ravi mentioned a really important point. I think I don't want to forget the important point that he mentioned was mood and participation and isolation, which Dr. Alice mentioned as well. A vital role of caregivers. I think this is one of the biggest challenges we are going to face in this country, particularly the number that we are doing about. I think, Dr. Ravi, I really appreciate the roadmap that you gave for India in dementia care. I think it's very, very nice. And I think you extensively mentioned about cognitive decline. I think as a psychotherapist, I think your intervention then was extremely very useful. I'm very sure participants would have really been benefited. The chats are mentioning that your talk so far, both the talks have been excellent. Thank you very much. Here comes Dr. Mrs. Miss Sugavana. Thank you.
Hi, am I audible?
You are very much audible.
Okay. Hi. Yes, I will try to touch upon some amount of BPST management as well as management for what we hope to cover as person-centered interventions. So I think already Dr. Alice had touched upon what person-centered care is. This was a concept that was introduced by Tom Kitwood, and it involves tailoring a person's care or care plan involving and including their interests, their abilities, their history, their personality. So it's a shift away from the traditional biomedical model. Uh, it's a huge shift away from what we have known as the medical model in most of our, especially in a country like India, and most of our hospital settings. So, what does this look like in clinical practice? It is that for every person with dementia who we see, every family member we might meet, or every person we meet socially with dementia, it's important for us to take into consideration their their personality, their personal history, who they are. Try to help them conduct meaningful activities, whether it's in an outpatient department, whether it's an inpatient department, anywhere in a clinical setting, to make quality of life and well-being their priority. And of course, the role of the healthcare professional and their relationship with the person with dementia. Recent literature has indicated that the role of the healthcare professional and the manner in which they speak, they respect, they communicate with a person with dementia, especially in care homes, that is inpatient settings, plays a very big role in the day-to-day quality of life of the person with dementia, how they perceive themselves, how they perceive their lives, their well being. So, the healthcare professional's role in just communication is a big aspect of person centered care. So, overall, understanding the person with dementia is the core of person centered care. So, it revolves around respect, giving them as much choice as possible, dignity, self determination, and purpose in living. The purpose in living comes from what we understand as the person's interest, the person with dementia's needs, the person with dementia's likes, while taking into consideration who they've been in the last 30, 40, 50 years, as well as their current symptoms. So, Tom Kitwood is who spoke about person centered care back in 1988, and since then it's been developing as a concept in dementia care. And it largely, what the main thing he said was that he believed that the environment has as much of an effect on the brain as the brain has on the person's abilities. So we are very aware of the cognitive deficits that occur in dementia, but the environmental changes, the social changes that we need to make are just as important as the cognitive deficits that we might be helping them with. Two very important aspects that go hand in hand with person centered care, one of which is selfhood. Selfhood is more than just their cognitive abilities, their memory, their any cognitive changes that we might notice. It is who the person is. How they communicate comes secondary. It could be through written language, it could be through signage, it could be in any manner, but who they are and preserving that social identity is essentially selfhood of the person. The second aspect that's very important for understanding is the relationship that the caregiver plays. I think that that's already been covered really well by Dr. Samuel, but I'm just going to touch upon it here. The relationship the caregiver plays increases over time as the illness deteriorates. So the role of preserving the person's identity falls more and more on the caregiver as the illness deteriorates, because the person with dementia might not be able to do it themselves. Often what happens is in a care home or in a hospital setting, there is a lot of disempowerment, there's a lot of labeling. Because of multiple factors, the person with dementia is labeled more and more by his or her illness and not by his or her identity as much. All of these factors are recently being shown to have very, very negative effects on the mood of a person with dementia, on their well-being, on their quality of life, on just their general day-to-day status. So once again, this has been touched upon, but essentially, Tom Kitwood spoke about how a person with dementia's main need is love, And it's characterized by a need for attachment, comfort, identity, occupation, and inclusion. So when we have distressed behavior or when we have BPSD, Kitwood spoke about how BPSD is a result of an unmet need, an attempt to get the need met. So someone who we see who has dementia who's shouting and screaming isn't shouting and screaming because they want to throw a tantrum or create a ruckus. They're shouting and screaming because they have a need. Maybe they're in pain, maybe they're confused, maybe they don't know where they are. It's causing a lot of disruption within them, which is their need at that point, and it's being expressed in the only manner that they at that point know how to express it. It's a method of communicating to other people that they have this unmet need, and the BPSD that we see is a product of their frustration because the needs are not met. So BPSD is essentially a combination of these factors. That's your biopsychosocial factors, your physical health, mental health, social environment, pre-morbid personality, which is what was the person's personality prior to this diagnosis or prior to any diagnosis, their life story, who are they, where have they come from, how have they grown up, where do they live, what do they like and what do they dislike, their cognitive functioning, what areas of their brain currently do we see as being resilient, as being positives, and what areas are they having some difficulties in, as well as their unmet needs. So when do we intervene? Do we always have to intervene if there is a different behavior in a person with dementia? Right. So maybe the person with dementia has started pacing up and down in the house. Now, is this pacing really distressing anyone? Is it distressing the client? Is it distressing other people in the house? Is it distressing the staff members? If it's not distressing anyone, if it's not disturbing anyone, do we have to intervene? Is the question. Maybe this is an expression of them feeling restless. Maybe they don't have an occupation anymore like before. So this is a symptom because of an unmet need. But if this is a need that is only affecting a staff member, it's not, doesn't seem to be distressing the client. More recent literature talks about how if it's very mild stress that's going on to the staff or onto family members, then we try to take care of that distress rather than trying to change the behavior alone. If, of course, it's distressing the client and the staff in very, very negative ways, we try to intervene with the behavior itself and change it. But it's also really important to take care of the staff or the caregiver's needs, because there is, like Dr. Samuel mentioned, going to be caregiver burnout. And if their emotional needs are not taken care of, they're not going to be able to take care of the person with dementia's needs. So, very briefly, creating a care plan for anyone, whether it's a family member or whether it's in a clinical setting, it's important to remember that dementia does not progress in a linear fashion. It varies from person to person. There's no symptom one, two, three, four, five. It doesn't progress in that order. It's important to focus on selfhood, which is more than just their cognitive abilities. Personal factors of the care professionals is found to play a very big role in how the the caregivers interact with their loved ones. So, whether it is the amount of knowledge they have about dementia, the acquired skills that they have, or the beliefs about personhood, they all play a role in their interactions. And finally, it's important to understand that there's a changeability of dementia symptoms, and there's an association with the well-being through their own, that is the person with dementia, and others actions. So a care plan essentially that we create for anyone with dementia has to be ever changing, whether it's on a weekly basis, on a monthly basis, because their needs are going to vary. Our care plan has to vary. Communicating with a person with dementia, like with most of us, involves all of these. So, like this, I really like this caricature here because it's talking about how the person with dementia is trying to communicate something, has a word finding difficulty here, has an aphasia here, and isn't able to communicate it. The people around him are trying to guess what he's trying to say, and whether they actually figure it out or not is anyone's guess at the end. But it's important to remember that basically communication for anyone involves them focusing on their attention, finding the right words, comprehending what's being said back to them, remembering the relationship they're in, remembering the context of the communication, and managing our emotions. Now, for a lay person who doesn't have any diagnosis, it in itself, it's often a lot of work. Now, for someone who has dementia, who has cognitive deficits, who has all of the other complications that they might have, it's doubly difficult. Person with dementia who has word finding difficulties is likely to be frustrated. That frustration is likely to show up as what we call as BPSD. BPSD in turn is likely to be met by most caregivers as frustration or irritation over time because they don't know what to do. They don't know how to solve this, which in turn leads to more emotional arousal in the person with dementia and finally worsens the initial symptom. So it's a vicious cycle that goes round and round unless healthcare professionals are likely to step in, or someone, the psychoeducation is likely to step in and help the caregiver here understand that they have to moderate their emotions to help moderate the person with dementia's emotions. So, the first step of any management, especially in dementia, is of course prevention. Prevention of the disease, of course, but also prevention of BPSD of any kind. So, to prevent this stress and distress or the behavioral symptoms, we can maximize communication, show respect, encourage choice as much as possible, give them choice, prevent and manage pain, meet their basic needs, their physical health, and engage in activity, whether that's cognitive stimulation or there is any other arts, drama, any activity. So, if the model on the right is talking about how all behaviors often have triggers, the triggers could be any of the seven domains. The behavior, of course, is to understand why this behavior is occurring and to prevent it from recurring. We have to look at the behavior, the vocalizations, and the appearance of the person when it's happening. It's rarely ever just the behavior. So, once we identify the needs and the possible thoughts that this person is having, it's important for us to try to meet this need because that is the most sustainable way for us to reduce BPSD or distress from reoccurring. So, some of these interventions that are mentioned here are also ways to meet the person with dementia's needs. I'll briefly touch upon those interventions now. One, of course, is cognitive engagement. So, cognitive engagement fulfills the need of occupation largely, whether it's reminiscence therapy, whether it's reality orientation, whether it's validation, cognitive stimulation therapy, which is, of course, a combination of all of these, or just music, or using dolls, art therapy. Any of these, or a combination of any of these, is found to fulfill the need of occupation. Life stories are very important and meaningful activities because they're also a part of reminiscence. Caregiver support, like doctors already spoken about, fulfills the need of inclusion, attachment, and identity for the person with dementia. If the caregiver is able to support them without reaching a very frustrated level, it's likely to fulfill a lot of the attachment needs of the person with dementia. Environmental modification largely focuses on the comfort and the need for inclusion. So, whether it's your lights, sounds, using signage within the house, making the bedroom more specific to that individual's needs, keeping a bathroom light on all night, or using different colors for the bathroom flooring versus the bedroom flooring, removing mats if there's a chance of falls, right? Making you sure that the person with dementia is using assistive technology if they're going to step out. Controlling temperature, because often BPSD occurs when they are trying to communicate something, and something as simple as it's too hot or it's too cold can also lead to distressing behavior. This is an example of some of the assistive technology that we can often use. And assistive technology also really fulfills the need for independence and having a sense of identity. So some more recent evidence has indicated, since there was questions about interventions that can be used, this is something that's very newly come out, which is person-centered meals using a Montessori method. So a Montessori method focuses on respect, dignity, and equality. And meal times are culturally, across cultures, found to be a way of social interaction, showing your preferences, and a sense of identity. So the Montessori method, this is of course from one research paper that has tried this and has found it to be very efficient, which is making minor changes in the dining room area for this person with dementia, which is changing the tablecloths, removing plasticware. This is a Western study, so they culturally use a lot of white china there. So using china instead of plasticware, placing condiments on the table, giving them access to adding salt or pepper. This is of course keeping in mind their physical health needs also. Minimizing any noise or interruption during meal times, and drawing benefit from the smell of the food. So they're able to also have multisensory stimulation, which is very important for them. Further, they went on to using external memory support and orientation cues. So, signages, breaking the tasks down for them, putting small labels near a teapot to help them remember what are the steps in making tea. All of this was, of course, supervised tasks, but also laying out the food for them so they could serve themselves in more of a buffet style. So, it's again improving choices. So again, this is categories of interventions for persons with dementia to improve on person-centered care. I think this is again everything that I've already covered. So I'm just going to stop here. Thank you.
Thank you, Sugavana. I think you were like, Rajdhani Express. I think probably you put a lot of pressure on your time. But I think we extensively covered overall care aspects, being probably having, been in an institutional setup, your inputs were good, very interesting, very stimulating. Before I really ask one of the questions, one of the persons that asked for it, you showed a beautiful caricature of a of communication by a demented patient in a bed with half a dozen doctors, clinicians around them, and not able to communicate. Actually, how do you really understand? How do we really do that? How do you really do that? Let's look at a typical case, and then can you cite some example for people to understand how do you really communicate? Because I have gone this kind of experience in several aspects, but still would like to learn from you. Would you like to give us a small example?
Yes, sir. So, for example, if it's like I mentioned, it's important for us to, when I'm starting to see a new patient, or if this patient is even someone who I've seen 3, 4 times, this person with dementia, they're admitted in a hospital or in a care home of any sort. It's important for me to not just take down their symptoms and form a diagnosis, but to spend time with their family, with them. It's going to take maybe 2, 3, 4 days before I'm able to understand that this person communicates in a specific way. So, for example, we have clients who have often when they begin to have they have stomach pain or they have pain of some kind, their social interaction minimizes. They spend more time in bed. They say they don't want to talk. They say that they don't want to come for meals often. This is I'm referring to one client who I had seen who used to get gastric complaints and gastric pain. So he was unable to communicate to us that he had gastric pain, of course. So he wouldn't even really point at his stomach. But this was someone we learned from the family who usually enjoys food, who usually was very social. And even the first 2 weeks that we had seen him after his BPSD had settled, he was very sociable with the other people at the center. So why then was he all of a sudden the third week retreating to his bed, unwilling to come? It would often cause irritation when we forced him to eat and said, no, it's 12:30 now, you have to come for your meal. If you don't eat, you can't take your tablets. It just became a back and forth battle till we realized, okay, let's try to sort of use multiple soothing mechanisms and see how we're going to help him. So one thing was, of course, doing a physical examination, which in itself indicated he had distress in his stomach when that happened. But more importantly, getting him to write, showing him images and asking him what he related to the most, and also getting in his family members at that point. And to his family members, he sort of very non-verbally communicated that he is feeling low, he's not feeling good, he's not hungry. Of course, to us, he saw us as healthcare professionals, so he wasn't. He just wanted to be left alone. But the minute we brought in people who he did have a very good social connection to, his communication was about how all of this was happening. And so, by process of elimination, he was having no problems with bathing or with changing his clothes, or when he was left alone, there was no irritation. So, what really was it? So often it's process of elimination of what can it be, what are these person's needs, where does this really understanding the ABC of his behavior. So what is triggering his behavior? When he is triggered, does action A or B help soothe him, or does it worsen his behavior? Is an analysis that we would do like 3-4 times a day. Every time either a nurse or a psychologist went to his home, we would do this analysis.
We lost you. Dr. Suvana, I think Mrs. Suvana, we lost you. Hello. Hello. Hello.
Hi, sir.
I lost you. Yeah. Okay. Fair enough. Yeah.
Okay.
Thank you.
I'm not sure where you all heard me till.
Okay. No, it's fine. Carry on. I think you have explained everything.
Okay.
Thanks a lot for that clarification. Dr. Rajesh Shekharan had asked a question on long-term care. I think what you explained is very revealing. I don't think there's need to, respond anything more than what you explained. I think what you explained is extremely detailed one, very relevant. I think the three of you made great show today, and very grateful to three of you for making it a point to spend time. I think Dr. Alice gave not only what happens in America, but also, South Africa, but also spoke globally. What are the important aspects? I don't think any of us have overcome the fear that she's talking about even today. Whatever is our age, I think we're all the time worried about, keeping the mask in the pocket or in the handbag, but not wearing it, wanting to wear it, not wearing to wear it. Those kind of threats are always there. And Dr. Ravi Samuel explained absolutely, down to earth what exactly needs as far as a country level, what his projects are concerned. So I would really like to thank the three of you for coming. And I also like to thank all the participants who are, being very attentive, and a lot of chats, appreciating each one of you for your contribution. And with this, we'll close the session. Two things. One request is that kindly fill up your feedback, so that you get your certificate of participation. In addition to, we would like to know how we have done. The second thing is, tomorrow we have the third day, which is last day, and tomorrow's sessions are going to be two neurologists and a nurse. Let's understand, tomorrow the neurologists talk about what really happens, and both are extremely experienced people. One is from All India Institute of Medical Sciences, and second is from Care Hospitals and Nizam Institute, Hyderabad. They're all very experienced. They're doing down-to-earth work on dementia. I think it'll be very interesting to see, go beyond psychiatrist, person with drugs, moving on to psychotherapists, psychologists, and going into an expertise on community. And then tomorrow we are going to talk about, we have covered a very wide gamut of cover programs. Speakers would cover all the area of dementia care. I think this is the best way that we could sensitize people about dementia. Thanks a lot once again. Kindly stay back to fill up the forms. Thanks, Prabhakar, for taking all the arrangements and sending it. Any of you have any questions, please ask us. We'll be very happy to do. I think we'll try to share this, entire proceedings with you on Zoom in the next, once the programs are over, we'll likely to share with all those people who participated, who have given us the feedback today. Thank you very much once again. All the very best.